Hello and welcome to another Piper Pearl. Today's Pearl we're going to be looking at dyspnea. Now dyspnea highlights a bit of a fundamental problem with the way clinical education is taught. It's very easy as a teacher and realistically for the students to understand topics when they're broken up into little segments. So we often will teach primary healthcare as things that walk into the clinic and they're not really an emergency, and then we'll move on to teach emergency care. And it does set this perception that a lot of the times emergencies won't actually present at an outpatient's department, or they won't attend a GP's clinic. And you almost get this false sense of security that if anyone approaches you with a complaint, it's going to be primary healthcare, and if you get called to a scene, then it's going to be an emergency. But as you go along in your career, you'll learn that this overlaps all the time, and most cases, especially in dyspnea, will actually start by people presenting with a complaint. So today we're just going to go through the topic of dyspnea. We're going to have a discussion about what it is, and then the best way to conduct a consultation on someone presenting with shortness of breath in order to best treat them. So as always, we'll start with some key facts and points about dyspnea, and then we'll move on to the greater presentation. So it's no surprise, I'm sure, but dyspnea is not a disease. Okay, it's a symptom of many etiologies which we'll go through. Now the main causes, as a class of causes for dyspnea, is lung disease. Okay, that's the most primary cause, but then you have heart disease, obesity, and hyperventilation. Okay, so those four classes are the main causes of people presenting or complaining of shortness of breath. Of those, as mentioned, the most common of all those involves some sort of airway obstruction. Now, wheezing is often associated with asthma, but there are cases out there where people will have asthma, but they won't actually have any wheezes, and not all wheezes are associated with asthma. Okay, so other pathological states will, in fact, have a wheeze as well. Now, when you're talking about dyspnea, most people contribute dyspnea as an acute phase, so it happens within a couple of minutes or maybe an hour. But a state of dyspnea can actually occur over a series of weeks, believe it or not. Okay, so it is broken up as acute or chronic in its occurrence, but it can happen rather rapidly, okay, very rapidly when you're dealing with trauma, but it can also occur over a series of weeks, which means the body's able to compensate, which means the patient may be presenting in quite a bad state they don't actually realize. You'd be amazed what the body can compensate with before they'll actually present, and then by the time you do your examination, the person is actually in a pretty bad state. So having a closer look at etiology, as mentioned, dyspnea itself is not a disease. So the etiology can arise from really five main areas, with your respiratory, your cardiac, your neuromuscular, your psychogenic, and then your systemic illnesses as well. And of course, you can have a combination of all these things where they overlap. So respiratory causes may include your asthma, your acute exacerbation of chronic congestive diseases like COPD, pneumonia, pulmonary embolism, malignancies, and of course you've got your pneumothoraces and any aspiration as well. So most of them involve some form of airway obstruction or airway restriction as well. Cardiovascular causes may include our congestive heart failure, cardiac-induced pulmonary edema, acute coronary syndrome, pericardial tamponades, murmurs like Val's disease, pulmonary hypertension, and then you can also get general arrhythmias that will shunt the cardiac output, resulting in dyspnea. Neuromuscular causes outside of trauma are the most rare causes that you'll have. So the main ones that fit into the neuromuscular categories is your fractured ribs, your flail segments, and then obesity also fits into that category as well. And we can also get your actual paralysis of phrenic nerve and central nervous system nerves as well. Psychogenic causes is mostly sitting around that hyperventilation syndrome. Okay, so it is, when people hyperventilate, it does fit into the category as psychogenic, even though it may not fit nicely in your world of definition of mental health. It does have the link in the psychogenic space as opposed to any other structural problems. Other systemic illnesses of dyspnea can include your anemia, acute renal failure, metabolic acidosis is a big one, thyroid toxicity, cirrhosis, anaphylaxis, sepsis, angioedema, and even epiglottitis itself. So, because of its broad range of etiology, when someone comes in presenting of shortness of breath and it's been confirmed, the best place to start is you start with respiratory, because that's the most common cause. But if you don't have any respiratory symptoms, then you need to broaden the umbrella of your investigation in order to try to narrow down what etiology you're talking about in order to better treat the patient. Okay, having a closer look at what causes our dyspnea. So the pathophysiology of dyspnea pretty much lies hand in hand with the physiology of our respiratory centers. So dyspnea itself is a sensation of running out of air and not being able to breathe fast enough or deep enough. It results from multiple interactions of signals and receptors within the central nervous system, peripheral receptors like chemoreceptors and mechanoreceptors that are found in the upper airway, lungs, and the chest wall. The respiratory centers themselves in the brain is comprised of three main neural groups. That's the dorsal and ventral medulla and the pontine group. Now, each of these groups communicate with one another and work together as sort of like a pacemaker for potential respirations. When we look at mechanoreceptors, they're located in the airway, the trachea, the lungs, and all the way down in the pulmonary vessels. And each of them exists to provide sensory information of the respiratory system to the brain in regards to volume and how much lung space there is. Okay, so mechanoreceptors, baroreceptors, they work hand in hand to tell the brain how full or empty the lungs are. On top of that, we have peripheral chemoreceptors that are found in the carotid and aortic bodies. Both sites will monitor the partial pressure of arterial oxygen in the blood. However, hypercapnia and acidosis will also increase the sensitivity of these receptors, and therefore these receptors are also known to monitor carbon dioxide and pH level as well. Once these chemoreceptors are stimulated by hypoxia, they send a signal via the cranial nerve 9, the glossopharyngeal, to the brain, which in turn stimulates the excitatory neurons to increase ventilation. It's estimated that these bodies, carotid bodies, comprise about 15% of our respiratory drive. When we look at central chemoreceptors, these hold majority of control over the respiratory drive. They function through the sensing of pH changes within the central nervous system. Primary location within the brain includes the ventral surface of the medulla. Now, when a pH change comes along within the brain and the surrounding cerebrospinal fluid, it's derived primarily by an increase or a decrease in carbon dioxide levels. So carbon dioxide is a soluble liquid molecule. And what that means is it can freely flow across the blood-brain barrier. It's not subject to the blood-brain barrier at all, so it can diffuse easily into the cerebrospinal fluid and therefore changing the pH of the cerebrospinal fluid, which is picked up by the central chemoreceptors to either increase respirations, decrease respirations, and also have a deeper breath. So this is actually what's happening every time you engage in physical activity as well. It's these sensors and receptors that are picking up on a decrease in oxygen or an increase in acidosis in order to increase our respiratory drive. In the absence of exercise, this is also what's happening to people with dyspnea. The body is in a state of hypoxia or a state of distress, and therefore the body is trying to catch up in order to catch their breath. Now, sometimes catching the breath is restricted by an obstructive disorder or a restrictive disorder or a cardiac disorder that's not actually providing enough blood to the lungs in order to oxygenate the body. Okay, let's move on with our subjective investigations. Now, when someone comes with a complaint of dyspnea, the first thing you do is you always have to ascertain if it's an emergency. So on first presentation, as soon as you see them, you need to ask yourself, is this an emergency? Now, this is true to everyone that walks into the room. You've got to denote whether or not emergency care is needed, as opposed to a prolonged consultation that you can do to track down the etiology and the best treatment. So always consider emergencies first. If it's not an emergency and you've got time, or whilst you're treating the person for an emergency, then you can start your investigation. The main thing we need to ascertain from the event is we need to make sure that it is in fact shortness of breath. Patients get confused, patients get worried, anxiety kicks in, and shortness of breath is pretty scary. So people may come in complaining of shortness of breath, but all they've got is a slight restriction in their throat or a tight feeling around their neck. It may not actually be shortness of breath. So get them to explain the shortness of breath to you so then you can grade how bad it actually is. We need to know when it started, how rapidly it started. If it's one of those ones that happened over weeks, they'll say things like, I don't know, I think I've had it for a while, it's getting progressively worse, and I just noticed it this morning, as opposed to I was running and all of a sudden I felt like I was dying. Ask how long it's been going on for. Can be hard for the patient to really pinpoint down, but ask anyway, and ask what states the patient is in that makes it worse. Things like exercise is a classic one that brings on dyspnea. People are perfectly fine compensating when there's not an increased demand. As soon as you increase the demand, it doesn't even have to be much. We can talk about climbing stairs, that sort of thing. It can increase the feelings of dyspnea. And then always ask if there's a cough present with the dyspnea, because it leads closer to having respiratory etiology. Past history is important. We want to know if the person is a smoker, has any anxiety concerns for hyperventilation. You obviously don't have to ask all these in order, but these are just investigations you can do. We also want to know the work environments for link to your interstitial disorders, which are the ones that involve some sort of inhalation of organic or inorganic substances that causes scarring and restrictions of the lungs themselves. We also want to know about recent illnesses, if they've had recent upper respiratory tract infections, lower respiratory tract infections, or any GI problems as well, because gourds can also contribute to your feelings of dyspnea. There isn't really any specific subjective questionings that you can dive into in regards to dyspnea. Most of the information we get will come from objective findings as opposed to asking the patient. Allergies, there is a link to asthma, but obviously you can ask allergies if you believe you're going to give medication. And there's no real medication out there outside of allergies that has been directly linked to dyspnea. So just having an understanding of what medications they take, which includes their current, over-the-counter, and any natural therapies, can give you an idea of the patient and also their current health status as well. So that's it for subjective investigations. Not a lot to ask because we're dealing with shortness of breath, so we really want to delve in and get the data from the body in order to make a better decision. So I can't reiterate it enough. If you think it's an emergency, at any stage, treat the emergency. If you think the patient needs oxygen, don't wait till the end when you get to the treatment part. Give them oxygen before you move on. Okay. When we're looking at vital signs, we obviously need to take them, and this time we need to take into account particular vital signs. So the main ones to look at is SpO2 heart rate, and respiratory rate. These will give us an awesome indication of whether or not the patient is compensating in a rest state for an increased need of oxygen. So decreased SpO2, increased heart rate, increased rest rate is obviously indicative of compensation, and we can use that information to see how bad the patient is. Having a look at their BMI, you don't necessarily have to take their height and weight right there at the first consultation, but just having a clinical judgment of someone's BMI. That's a little bit tricky when you're dealing with large muscular people because their BMI is obviously going to be high, but when they talk about BMI being a problem for neuromuscular problem for dyspnea, they're talking about people that are carrying a large amount of weight on their chests and have a huge obstructive body sitting underneath their diaphragm. Okay, they're the ones that are more susceptible to dyspnea from obesity, okay, not the people with broad shoulders and big legs. So just make sure you distinguish the difference between the two classes of BMI. Temperature is important. If someone has a temperature, is more likely to be a respiratory infection. Overall, because we're dealing with dyspnea, we need to look for signs of hypoxia. Easiest one is obviously SpO2, but we can delve deeper if we need to. We want to look at the person's respiratory effort. So you want to have an inspection of the person's respiratory effort, and you're looking for the use of accessory muscles. Is the person using their intercostal muscles? Are they raising their shoulders? Do they have a tracheal tug? All these sort of small clues that you can pick up that denotes whether somebody's breathing effort is increased. Auscultation and percussion is vital, must do, and I'm doing a separate presentation on auscultation and percussion of the chest region, so have a look out for that one. That pretty much covers the respiratory side, and that's where we start. Being the most common etiology to present for dyspnea, we always start with respiratory findings first. If respiratory findings are completely fine, then we can move on to further investigations. We can have an inspection of the abdomen, and we're looking for things like ascites. Is there in fact another reason that there's a large obstructive body underneath the diaphragm? Looking for the extremities for your edema. Okay, we'll see if there's any link to the heart. If you have any respiratory findings initially, we can increase our understanding and our differential diagnosis by performing a peak flow and a spirometry. And the spirometry can include respiratory dilators like salbutamol in order to denote whether or not it is an obstructive disorder versus a restrictive disorder. I'm also going to be doing a lesson on peak flow and spirometry interpretation, so stay tuned. Deeper investigations, probably outside of the initial consult, include blood tests, x-ray, and a 12-lead ECG. A 12-lead ECG is not a bad idea if you've ruled out any respiratory concerns and or if the patient is actually quite acutely ill. Having a ECG is a very, very good idea. Okay, X-rays can be a decision that you make in order to ascertain what sort of consolidation within the chest cavity. And bloods can include things like your full blood count to look for anemia is a big hidden one that often gets underdiagnosed with cases of dyspnea because it's very, very slow to kick in. Once you have all the information, we need to do our assessment. We need to ask ourselves, is it an emergency or not? Remember, compensation is a thing. Patients with chronic conditions compensate excessively well. So you may not find that it is an emergency until after your objective investigation. You need to try to figure out what sort of cause it is, respiratory or the others. Ask yourself, can you treat it? Can you provide any symptomatic relief for the patient right now? Should you refer this patient or should you evacuate this patient to higher care? These are questions you need to ask yourself. If you're dealing with respiratory, then we have a few things that we can look at in order to distinguish between them. Now, the first two, when we're dealing with chest wall movement and mediastinal displacement, they are very difficult to ascertain. People throw them away in textbooks saying it's quite easy to have a look at chest wall movements. It's difficult. because we're not talking about a large paradoxical problem like a flail segment. We're dealing with very small, subtle differences. In order to see chest wall movement reduction based on consolidation from lobar pneumonia, I would be incredibly impressed if you pick that one up. Okay, so have a look. If you note it, fantastic, but realistically, it's a very, very difficult sign to find. But moving along to things like percussion, breath sounds, vocal resonance, and added sounds, that's something that we can absolutely ascertain, and it will be given to us based on our auscultation. So I won't go into too much detail on the different types of breath sounds in this lesson. It's the sort of thing that we're going to cover in the auscultation percussion lesson. But just know that when you are doing an auscultation, you are listening for the quality of the breath. So you're actually listening for the vesicular and the bronchial sounds. And we're listening for additional sounds like crackle, wheezes, stridor. And you can also do something known as vocal resonance, which is getting the person to talk and hearing whether or not it sounds like they're talking into a barrel, or if the sound can actually vibrate off something solid like consolidation, blood, whatever's in there, in order to create a deeper sound. You may be looking at the list on the left saying a pneumothorax isn't going to walk into a clinic, but spontaneous pneumothoraces or small pneumothoraces that get slightly larger out of benign trauma do in fact come on presentations with dyspnea, and you can pick them up. They can be difficult to pick up, and they're only really found on a chest x-ray or after you do a chest auscultation. Okay, moving on to treatment. Education on asthma control. Someone comes along and they have been diagnosed and it's definitely an obstructive disorder leading towards asthma, then they need to know about their asthma control. If they have an asthma plan, you need to reiterate that asthma plan. You need to get them to look at preventative, early treatment as opposed to waiting for it to get to the point of shortness of breath. So educate them on the early signs of dyspnea, which can include basically getting out of breath walking up a hill. If you're usually a fit person and you don't get out of breath doing minor exercises, and then all of a sudden you are, that's an early sign of dyspnea. Believe it or not, it's actually your respiratory rate is the first thing that changes in your body physiologically when the increase of oxygen demand is there. When we're dealing with treatment, oxygen therapy can be good, but only give oxygen therapy if it's needed. Just because they're short of breath doesn't mean they automatically need oxygen. So gauge it off the SpO2 and give them the appropriate amount. Nasal prongs are perfectly fine. Bronchodilators are fantastic if you're dealing with an obstructive disorder. If you have a restrictive disorder, bronchodilators don't really do too much. The restriction is often caused by scar tissue, which means you can dilate until the cows come home and nothing will actually happen. So if it's a obstructive disorder, taking away bronchodilators and an MDI can be a good treatment in order to support them. They can also be given corticosteroids if it's needed. It's more of a preventative of inflammatory based problems, and antibiotics are rare, but in cases like pneumonia, sepsis, that sort of thing, then yeah, antibiotics definitely are considered as a treatment. Restrictions are going to be difficult because most of these patients will need to be referred. Okay, if you have a patient that is suffering from dyspnea, they're going to need to be referred most of the time. If not, restrictions can obviously be played by ear. It's like stopping PT, certain work environments, removing them from the field, rest at home. Consider the patient's care. Look after the patient with restrictions. Look after their workplace. Consider work health and safety considerations and provide the restrictions that are needed. Okay, that brings us to the end of the lesson on dyspnea. Just remember when you're doing your clinical consultations in an outpatient department, just because people walk in complaining of a symptom does not mean that that symptom they're complaining of is not an emergency. Epistaxis is a classic one. Patients can be stoic. You'll find it all the time that a patient will not actually come to an outpatient department until they're on death's door. By that stage, you need to be able to ascertain quickly whether or not you need to change your management process from a consultation to an emergency management mindset. But until next time, take care.